Good evening, everyone. Thank you for coming. Good evening, everyone. Thank you for coming here, for spending time together for this lecture on Good evening, everybody. Thank you for coming here, for coming to this short lecture about sleep interventions, about sleep science. Good evening, everyone. Thank you for coming here for this short lecture about sleep science and interventions. Allow me to share screen. My name is Dr. Arlene Merton. I am a double diplomate. First of all, I'm a diplomate of the Philippine Board of Otolaryngology. I'm a fellow of the Philippine Society of Otolaryngology, Head and Neck Surgery. I am a diplomate of the Philippine College of Lifestyle Medicine, and I am a diplomate of the International Board of Lifestyle Medicine. Today, we are going to be discussing sleep sciences and interventions. The following are the objectives of our lecture: to understand the physiology of sleep, to understand sleep's role in health and chronic diseases, and to identify lifestyle-based activity and the dietary, environmental, and coping behaviors that can improve sleep health. For the source of my lecture, it is the Lifestyle Medicine Board Review Manual, 2nd edition, which was put together by the American College of Lifestyle Medicine. First, let's discuss sleep and culture. There are certain barriers in getting enough sleep. First, there could be a conscious limiting of sleep. There's the viewing of sleep as inconvenient or wasted time. And being able to function on a small amount of sleep is equated with courage, strength, or productivity. I remember when I was a medical school student, I would be able to function during the SGDs and during the exams on 30 minutes of sleep. I would just drink lots of caffeine during the daytime. For other people, early mornings or late evenings may be the only time available for focused, uninterrupted work. This especially applies to people who have multiple jobs or those who have families taking care of their young children or taking care of the household chores. And there is an estimated 20% of workers are on the night shift. For the sleep statistics, the average US adult sleeps 6 hours and 57 minutes, 20% sleep less than 6 hours per night, 37% of young adults sleep less than 7 hours per night. About 60 million US adults have difficulty sleeping, of only which 10% seek medical attention. The indirect costs of insomnia are estimated to be around $60 billion annually and include letter A, presenteeism, which means that the person is present in work but is not being productive, and increased risk of long-term disability. Later on, we're going to be discussing the chronic diseases which are related to lack of sleep. Now, I'd like to ask you, as a medical student, how many hours of sleep do you get per night? And do you think it's healthy? And if ever you are not getting a healthy amount of sleep, what are the barriers which are preventing you from getting enough sleep? The amount of sleep we get, 1/3 of life is spent sleeping. The general requirements is 7 to 8 hours per day, but there is no recognized objective test for how much sleep a person needs. There's a considerable range in sleep needs from person to person, and often these persons are unaware that they lack sleep, even though it impairs functional performance. To understand sleep, let's discuss the circadian physiology terminology. Circa means about, and dia means day. This is the internal clock, which are the endogenous, or the internal, meaning within the body, circadian oscillators. These are the molecules, cells, and tissues. They produce oscillating or alternating currents through self-regulating positive and negative feedback loops that create the circadian rhythm. The endogenous oscillators are located within the body, and we have the central oscillators are located within the central nervous system, and the peripheral oscillators, which are located elsewhere. The central oscillators consist of the suprachiasmatic nucleus, which is the main body clock. It's a bilateral structure located in the anterior part of the hypothalamus. While the peripheral oscillators are present in every major organ in the body, and these include your kidney, liver, heart, adrenal glands, and pancreas. They allow for synchrony and alignment between the central and peripheral clocks. The circadian rhythm is a biological process that are regulated by central and peripheral oscillators that are capable of being brought into a rhythm, which is usually a 24-hour period, in order to help align physiologic functions and behaviors with solar light-dark cycles. What this is saying is that the major trigger for the sleep-wake cycle is darkness and your light. Entrainment refers to the ability to be brought into a rhythm. There is synchronization of the internal endogenous oscillators based on the external or out-of-body inputs. An example of entrainment is when you travel abroad and there is a large disparity between the two countries. You must now entrain your body to adjust to the time of the new country by using exogenous triggers such as your sunlight, etc. Sleep propensity refers to the ability to transition to sleeping if a person is awake, or to stay asleep if a person is sleeping. The wakefulness sleep cycle is entrained by the day-night cycle. The awakening cortisol spike, which we'll discuss later, is entrained by food anticipation. Now let's continue to the circadian rhythm. First, we start with the suprachiasmatic nuclei. Here, this is called the central clock, and it's the portion of the hypothalamus that regulates melatonin secretion by virtue of the pineal gland. Nerves from your suprachiasmatic nuclei directly connect to the other tissues and organs, allowing for entrainment and control of the circadian rhythm. For example, the core body temperature, if we are falling asleep, the core body temperature here will decrease while the peripheral body temperature will increase. And when we are about to awake, the core body temperature will increase while your peripheral body temperature will decrease. The neuronal tract from your suprachiasmatic nuclei The neuronal tract from your retina to the suprachiasmatic nuclei is used to entrain the central oscillators. In other words, the retina is one of the main indicators or one of the main triggers to entrain your suprachiasmatic nucleus. The neuronal tract from the suprachiasmatic nucleus to the pineal gland, controls melatonin secretion. Next, from the suprachiasmatic nucleus to the autonomic nervous system innervates the adrenal glands. Adrenal glands help regulate the blood flow, temperature, and food intake through the secretion of epinephrine, norepinephrine, glucocorticoids, and aldosterone. This is the pineal gland. It's located deep within the brain in an area called the epithalamus, and its function is to secrete melatonin. These are the factors responsible for the awakening cortisol spike. First of all, we have the retinal ganglion cells. These are non-visual, light-sensitive retinal neurons. These relay light intensity or spectra to the suprachiasmatic nucleus. Melanopsin is a photopigment in the retinal ganglion cells and is the pathway that the suprachiasmatic nucleus clock is entrained. Melanopsin is maximally sensitive to short wavelengths of light. Examples of this blue light are your laptops, computer monitors, smartphones, your TV monitors, and fluorescent lights. So we are maximally sensitive to those. Wavelength refers to the frequency of light. Different wavelengths are perceived as different colors by our retinal ganglion cells. The retinal ganglion cells are stimulated, which relay the intensity and spectrum to the suprachiasmatic nucleus. Based on this signal, melatonin secretion timing may be changed. Again, here is another table of the circadian system components. We have light, which affects the suprachiasmatic nucleus, which is a central oscillator, which in turn stimulates or gives signal to your adrenal gland and controls the secretion of glucocorticoids, which in turn will also affect the peripheral oscillators. Your central oscillator will also affect your temperature cycles, leading to your core body temperature decreasing or increasing. Feeding and locomotion can also affect your temperature cycles, which will lead to peripheral oscillator changes to regulate your circadian rhythm. Here we will discuss the cycle of stimulating the endogenous oscillators. First, we have the inputs. The inputs are the external and environmental factors that will entrain the circadian rhythm. These are located outside the body. First, we have light, and the intensity will matter, no? The wavelength will also matter. We already discussed that we are maximally sensitive to blue light. Food or carbohydrates. A high carbohydrate diet will push back our sleepiness. Fluids or osmolality, which is a measurement of the particles such as your sodium, potassium, and chloride in the blood. If you have high sodium in your blood, your feeling of sleepiness will be pushed back. And ambient temperature, because this will also affect our peripheral body temperature and our core body temperature, which will also affect our feelings of sleepiness. Next, we have the modifiers. These modifiers, these will change the amount of input that gets to the body's operators. These will modify, for example, the pupillary reflex in the eyes. These will modify the amount of light which we perceive, right? This limits the amount of light getting to the retinal ganglion cells. Same with the sunglasses, it changes the intensity of light reaching the retinal ganglion cells. These are your single nucleotide polymorphisms. These are genetic variations in the DNA which occur in the gene coding portion of the DNA. Excuse me. No. And these have a very vital role in the entrainment process. For example, exposure of the retinal ganglion cells to light will cause more PR protein to be produced, which is an important factor for the perception of light and the perception that it's time to be awake for the body. Next, we have your cutaneous fat stores. These affect the core and extremity temperature in a way. For example, if there is not enough fat, if there is not enough fat stores, you can accelerate the changes in your body temperature. Or if there's too much cutaneous fat stores, these will affect the body's ability to thermoregulate. Vascular tone, this affects fluid volume in the blood vessels, which modifies your core and peripheral temperatures. For example, your nitric oxide and your estrogen, these are vasodilators, which will increase the body temperature in the area. And for your sodium, these will cause vasoconstriction, which will lower the body temperature and also increase your blood pressure. Next, we have operators. The operators are the body's reaction or response to the modified inputs. How does the body respond? For your core body temperature, there are changes. It either decreases or increases your melatonin secretion or suppression, your cortisol secretion, the timing of cortisol spike, and your cutaneous blood flow, either increasing or decreasing. Next, after operators or the body's response, we have the outputs. What is the behavioral and physiological consequences of the operators? We have the alertness, kinetic activity, the food-seeking behavior, the sleep or sleepiness, motor skills, including the precision and strength of your motor skills, and so on and so forth. Next, we'll discuss the circadian and sleep physiology. We're going to discuss the sleep onset, the early sleep, and the later stages of sleep. We'll start with the sleep onset. Darkness triggers pineal melatonin secretion. So there is melatonin secretion, which causes cutaneous vasodilation, extremity warming, cooling of the core body temperature, and sleep initiation. In the stages of early sleep, which is the sleep onset to mid-sleep, there's a continued rise in the melatonin levels. There is increased peripheral skin temperature and the continued cooling point of the core body temperature. And the lowest core body temperature will reach the lowest point 4 hours after sleep onset. At this point, we have predominantly slow wave or restorative sleep on the EEG. There is decreasing core body temperature with increased peripheral skin temperature, and this signals the physiologic restorative processes throughout the body. There is also decreased blood pressure and sympathetic tone. Next, we have throughout the sleep, there's restoration, right? So we have DNA remodeling and repair, leptin secretion, which controls appetite. Leptin is the hormone, which is the satiety hormone. If you have increased levels of leptin, you have increased feelings of satiety. This is versus your ghrelin, which is the hunger hormone. There's a gradual increase in cortisol in preparation for awakening, and there is fatty acid metabolism. Next, we have late sleep, which is mid-sleep to awakening. There is declining melatonin levels, decreasing peripheral skin temperature, and increased core body temperature. There is longer rapid eye movement periods, which is important for fear extinguishing, and increasing blood pressure, sympathetic tone, and baroreceptor sensitivity as the body prepares to awaken. To review, your baroreceptors refers to the body's ability, right, to change your blood pressure by modifying your heart rate, heart contractibility, and your peripheral vascular tone. Next, we have the awakening. There's a cortical spike. This is the highest cortical spike in a 24-hour period. Normally, the peak cortisol level in a 24-hour period occurs upon awakening. This spike is important in the transition from sleep to wakefulness. Next, I want to show you, here's a graph of the core temperature, sleep propensity, and melatonin levels. And we see the relationship between insomnia and body temperatures. Here's the relationship between insomnia and body temperatures. The core body temperature, which is the solid line, it decreases during the sleeping period and increases again when you wake up. For the sleep propensity, here it is. This is in the context of a 24-hour clock time. And your melatonin secretion is also at the peak during the sleep period. Next. We have to understand sleep's role in health and chronic diseases. For the sleep disorders, we have the behaviorally induced insufficient sleep syndrome, or the BIISS. This is voluntary, The patient voluntarily restricts his or her sleeping time. I think for us in the medical field, we have, or all of us at one point, underwent this behaviorally induced insufficient sleep, like when we prepare for exams or when we are in duty in the hospital. So it's part of our training. There's inadequate sleep for functional performance. And sometimes we think na bawi ko in Nika weekend, no? So in Nika weekend, we have longer sleep duration. This is still not a healthy habit. There is a disparity between the sleep needed and obtained. The prevalence is 7.3 to 20% of the general population. The associations are younger age, 30 to 39 years old, alcohol abuse, and longer work hours, more than 40 hours per week, sleep, and depression. Insomnia is difficulty initiating or maintaining sleep at least 3 times a week for 3 months. There is a criteria for insomnia, so take note of this, 3 times a week for 3 months. It has, and also there are other tenets to be considered, or they should be met. There should be daytime consequences, and there should be adequate sleep opportunity. This is associated with fatigue, malaise, and sleepiness. Insomnia is associated with fatigue, malaise, sleepiness, concentration or memory impairment, decreased motivation, mood disturbances or irritability, errors or accidents at work or driving, and physical symptoms such as headaches, GI distress, and persistent worry about sleep. We do have obstructive sleep apnea. This is recurrent apnea or hypopnea during sleep. Apnea meaning cessation of breathing. Hypopnea meaning that there is decrease in your O2 saturation during sleep, lasting 10 seconds to 1 minute, usually 5 to 30 times or 5 to 30 episodes per night. This is quantified as your apnea-hypopnea index based on your polysomnography or your sleep study. And your OSA, obstructive sleep apnea, is classified as mild, moderate, and severe based on the number of episodes of your apnea and hypopnea during sleeping. If there are only 5 to 15 episodes, this is mild, 15 to 30 episodes, moderate, and severe if there are more than 30 episodes. The prevalence is up to 26%, up to 26% of the general population, in which 80% are undiagnosed. This is associated with overweight or obesity, the metabolic syndrome, which is a syndrome which consists of your high blood sugar, hypertension, low HDL, high triglycerides, and excess central fat. Hypertension, increased neck circumference, and loud snoring, which indicates increased increased airway resistance when you are sleeping. We do have restless leg syndrome. There's a feeling or an urge to move the legs, which can occur with an uncomfortable sensation in the legs that happens when one rests, sitting or lying down. It's worse in the evenings than during the day. Movement helps to relieve the uncomfortable sensation and the urge to move one's legs. Symptoms are not due to another primary medical cause. This is present in 5 to 15% of the US population and associated with periodic movements of sleep, which occurs in 85% of patients with restless leg syndrome. There is disruption of sleep, fatigue, and periodic involuntary and jerky movements of the limbs while awake or at rest. We have other sleep disorders. Your short sleep misperception, which is a mismatch between the sleep duration recorded on polysomnography and the patient's subjective interpretation of the sleep that he gets. The patient perceives less sleep than the actual sleep duration. We have secondary insomnia, probably due to medications, vascular dysfunction, for example, peripheral hypoperfusion, vasospasm, visual impairment, opacification of the eyes, retinal degeneration, in which your retinal ganglion cells cannot easily identify if there is light. And your renin-angiotensin dysfunction or your fluid imbalance, it affects the osmolality of the blood. Narcolepsy is a sudden, uncontrollable onset of sleep. It's appropriate to refer these individuals for a sleep study and a sleep medicine specialist. We do have periodic limb movements, not to be confused with your restless leg syndrome. These are limb movements occurring at about 30-second intervals during sleep. There is increasing frequency with age, especially after 50 years old. It is often associated with the restless leg syndrome. Patients may report restless sleep or middle of the night awakening with increased daytime sleepiness. What's the connection between sleep and metabolic disorders? Healthy sleep duration and quality will lead to lower cortisol and glucose levels, greater insulin sensitivity, and higher daytime leptin, or your higher daytime. This is the hormone for we mentioned it earlier, food satiety, and reduced food-seeking behaviors. Do you remember what's the opposite of leptin? It's ghrelin. Ghrelin is the hunger hormone. Whereas impaired sleep quality and short duration will lead to higher nighttime cortisol and glucose levels, reduced insulin sensitivity, higher glucose levels, and lower daytime leptin levels, and higher intake of carbohydrate-rich foods. Men and women who slept 4 hours or less for 5 nights in a row sought out approximately 300 calories more, and especially calories from saturated fat during the day. Short duration and disrupted sleep correlates with elevated BMI, obesity with a ×2 risk, increased risk, metabolic syndrome, and type 2 diabetes. What is the connection between sleep and cardiovascular disorders? Healthy sleep duration and quality leads to lower sympathetic tone and blood pressure, greater nighttime peripheral perfusion and core body temperature cooling, increased stamina, and faster cardiovascular recovery time. Whereas impaired sleep quality and/or short duration leads to elevated sympathetic tone, elevated blood pressure, especially at night, reduced nighttime peripheral perfusion, and increased nighttime core body temperature. Short sleep correlates with refractory and no reduction of blood pressure in the early morning hours, increased risk of heart attacks, increased risk of cardiovascular disease, deaths, and vasospastic disorders. What is the relation between sleep, mood, and cognition? Healthy sleep duration and quality sleep leads to a higher proportion of sleep time spent in your slow wave sleep, which is the stage 3, which is the deepest, most restorative stage of your non-rapid eye movement sleep. Higher proportion of your rapid eye movement. Your REM is responsible for anxiety and fear extinguishment. There's also faster cognitive processing and enhanced learning and memory. Impaired sleep quality and short sleep will lead to less slow wave and REM sleep, reduced brain-derived neurotrophic factor, which is a key substance that triggers repair and regeneration of the nerve tissue, impaired learning and memory, emotional distress, impaired moral judgment, misinterpretation of social cues, decreased alertness and cognitive processing speed, diminished fear extinguishing as the amygdala is not able to get rid of the memory of fearful events. There are also psychiatric disorders which are correlated with short sleep duration. These are your major depression, bipolar disorder, seasonal affective disorders, and your PMS. In fact, studies have shown that your post-traumatic stress disorder or your PTSD is worsened if sleep deprivation happens 2 weeks prior to the traumatic event. And traumatic brain injury is worse with sleep deprivation if sleep deprivation occurs before or follows the brain injury. What is the connection between sleep health and cancer? If you have good sleep duration and quality, it helps with DNA repair and histone remodeling, apoptosis and anti-cancer cytokines such as your interleukin 1 and 2 and your TNF-alpha, whereas your impaired sleep quality and short duration will lead to melatonin and immune system suppression, increased cancer-stimulating cytokines such as your interleukin 10, dysfunction in gene transcription and cell cycle, and aberrant DNA methylation, meaning DNA expression is not being coded correctly. There are other cancers which are also correlated with insufficient sleep, such as your breast cancer, endometrial cancer, prostate cancer, colorectal cancer, and your acute myeloid leukemia. Now that we've discussed all of these chronic diseases which are correlated with insufficient sleep, quality, and duration, this is the most important part of the lecture, which is to identify the lifestyle-based activity and the dietary, environmental, and coping behaviors that can improve sleep health. We have your lifestyle prescription for sleep, which I'll show you later. And we must counsel the patient regarding the proper behaviors which can improve their sleep. Regarding the actions and sleep environment, use the bed for sleep and sex only. Establish regular sleep cycle for bedtime and awake time. Increase your bedtime peripheral cutaneous vasodilation through bath or shower, socks or heating pad for cold feet, and non-caffeinated tea or beverages. Next, allow air temperature to gradually warm extremities using beddings, socks, heating pads, and blankets. Minimize or eliminate bedroom noise and lights, such as your digital displays, your charger lights, alarm clock should be out of sight. Power naps may be helpful if they are less than 30 minutes. Light exposure, this is one of the most important parts of your interventions, no? Counsel the patient to increase daytime exposure to sunlight, ideally outdoors, open sky. Increase the daytime physical activity. Get up and move at least once an hour. Increase physical activity in the late afternoon and early evening. Decrease light at night. Turn off or dim unnecessary lights at least 1 hour before bedtime, especially blue light. Examples again of blue light. Do you remember? Cell phones, laptops, TV, compact fluorescent, halogen light, and backlit screens. Use 2500 Kelvin color warm spectrum lights. For the dietary interventions, eliminate nighttime caffeinated beverages, limit daytime caffeinated beverages, avoid alcohol within 3 hours of bed, eliminate after dinner and late night snacking. Avoid high sodium foods, especially at dinner, because it affects vascular tone and vasodilation. Assure adequate daytime fluid intake, especially in the late afternoon, because it affects vascular tone and vasodilation. And weight reduction if BMI is elevated. This is in relation to, we discussed already, aside from the cutaneous fat stores, this is also a risk factor for your OSA, obstructive sleep apnea. Minimize stress. Start sitting down 1 hour before bed, including active relaxation, bath, shower, meditation, guided imagery, music with 60 beats per minute. Develop a wind-down routine. Proceed from daytime concerns to restfulness. Stop working or doing stimulating activities 90 minutes before bed. Mitigate nighttime worrying, planning, ruminating. Try mindfulness-based stress reduction and meditation. And practice cognitive behavioral therapy techniques for insomnia. Intensive therapies, we have the cognitive behavioral therapy for insomnia. This is recommended as first-line treatment of chronic insomnia over medications. Again, the first-line treatment of chronic insomnia is not medications, not melatonin. It is cognitive behavioral therapy. This is more likely to produce sustained benefit, less risk of tolerance or side effects. The cognitive therapies combined with behavioral therapies have been shown to facilitate getting off sleep medications and sustaining sleep over time. There is also limited evidence that they reduce daytime fatigue. For other behavioral methods, these are other behavioral methods: sleep restriction, stimulus control, relaxation training therapy, and sleep hygiene. Among these 4 behavioral methods, sleep restriction is shown to be the most effective in moderate to high quality randomized controlled trials. We do have cognitive methods such as your cognitive restructuring. It addresses anxiety producing or erroneous beliefs about sleep or lack of sleep. Let's discuss supplemental melatonin. It's quite common nowadays that patients are taking melatonin because it's easily available in the pharmacy, over the counter, or even in healthy options, they sell melatonin. We'll keep in mind that there is significant inter-individual variation in endogenous melatonin. As we grow older also, sometimes the endogenous melatonin will also decrease. That's why some senior citizens or some older people have insomnia. They have difficulty in maintaining their sleep. This is efficacious for jet lag mitigation and circadian rhythm disorders. There is mixed evidence for insomnia. No evidence for adverse effects at typical doses of 1 to 6 milligrams, but possible interaction with some cytochrome P450 drugs, or the drugs that are metabolized by your cytochrome P450 in the liver. Supplementation does not appear to suppress endogenous melatonin, but there are no long-term studies. Sublingual preparation may have better bioavailability. Sustained preparation may be more helpful for jet lag, but it may cause morning drowsiness. Supplements with vitamin B6 may cause an acute altering effect in some individuals. Next, we have hypnotic or sedative medication use and mortality. These are medications that are used to induce or maintain sleep. These can include your benzodiazepines or over-the-counter drugs such as your antihistamine Benadryl, doxylamine. Prescription strength hypnotic medications are associated with a significant increase in death rates in adults aged 18 to 55 years old, and an increased risk of all-cause mortality in all age groups that used hypnotics from overdose, car accidents, falls, depression, cancer, and suicide. Here we have an example of a sleep prescription. This is provided by the American College of Lifestyle Medicine for pediatric and adolescent patients, with the understanding that generally school-age children need 9 to 12 hours of sleep per day. The purpose of this is to keep track of how many hours we sleep for 1 week, from Sunday, Monday, Tuesday, Wednesday, and we can analyze this to know if we have sufficient amount of sleep or not. And if not, what are some of the things that we can do to improve the quality or the duration of our sleep? That's our last slide. Thank you for listening. I hope all of you completed your assignment for the sleep prescription.